my talk is about the Uniportal plus decompression for lumbar spondylolysis. And first of all, I would like to ask all of you who perform the endoscopic, please your hand up. Okay, half of the room is a lot. I have no disclosure, and this is the spondylolysis, is the anatomical defect of the vertebral arch or the fracture of the pars interarticularis. And if they have the slip, we call the spondylolysis, right? This is the pathoanatomy of the nerve root compression. Normally the L5 root is tapped in the stenotic foramen by the bony hook, like the remnant of the proximal deficiency lamina up to the base of the L5 pedicle in the L5S1. So it is increasing the compromise by escalator of degree of the slippage. So I would like to ask you, when the L5 slip forward, do you think the nerve root was free or the nerve root was compressed? When you compare with the hangman fracture, right? The hangman fracture, the pars fracture also, but if the C2 forward slip, normally no neural deficit. But in the pars, defect is different. So I would like to show you forward slip, and you see the bony hook forward slip and impinge the nerve root, the exiting nerve root. Okay, that's why the spondylolysis have the exiting nerve root compression. It's not the traversing nerve root compression. Okay, and this is the endoscopic treatment by Anthony Young. He reported the transforaminal endoscope decompression in 55 patients, and he found that the good result in 18 months, and then you can see the good result dropped until 5 years. Only 3 to 33% is still good result. That means around 70% have to perform second surgery. This is our experience. The young man, 71 years old, come with the L5 reticulopathy, and you can see that this is the extra foraminal disc herniation on the L5S1. And I performed the transforaminal discectomy, and look at 1 year later, is have further slip. So what is the cause of the further slip in this case? In the spondylolysis, the iliolumbar ligament is the secondary leg stent to hold the L5. Because of they don't have pars, so they will forward slip. So the secondary leg stent is the iliolumbar ligament. It's very important. And also in the front is the disc. And in my patient, they have the disc herniation, and I remove the disc. And also I perform by transforaminal approach, so I damage the iliolumbar ligament in the same time. So that's the cause why my patient have the further slip. This is another study to confirm the associate with the post of further slip if we perform the transforaminal. So I recommend to avoid transforaminal approach in the spondylolysis. So in my experience, I perform decompression alone. The question is, decompression alone may cause further slip or not? Okay, this is my publication. You can read my publication, and you can know the answer of this question. I would like to ask all of you, in the case of L5S1 spondylolysis, if you want to decompression the pars, the entry point should be on the L5S1 or on the L45. L5S1, put your hand up. No. L45. Oh, that's good. Because of if you want to attach target to the pars, you have to perform L45 interlaminar withdrawal, and you will find the pars very easy. Okay, this is one of my case referred to me by the ankle specialist. She suffering from the burn sensation on the right ankle. And you see, the pars is the cause of the pain. And then I perform the endoscopy, identify the pars, and remove some parts of the pars until I can identify the L5 root and remove the bony hook that I showed you in the first slide. You see that? And this is our result. You can see before, after, we can free the nerve root, and the patient very satisfied for that. And what about the spondylolysis in the young? This is 17 years old, referred to me. He diagnosed this herniation on 4-5 and conservative for 6 months. And you can see the MI show that this degeneration and the 4-5. But many modality of the conservative treatment fail. And if you look at the pars, you can see the par defect, right? And the CT scan show clearly demonstrate the par fracture, and par is the cause of the pain. So in this case, I perform endoscopic decompression and percutaneous back screw to repair the pars because she is very young female. And what about the spondylolysis in the patient less than 40 and with the back pain? I perform the endolift in this case. You see, I perform with I put the screw first. Normally they put the cage first, right? But I put the screw first. And then I perform the discectomy. I use the dissector, and then I apply the rod to reduce, and then I will achieve the very good reduction by this technique, something like that. Okay, this also one case. Come with the back pain, predominant. If the patient come with the leg pain, and in the elderly, I decompression alone, but in the young patient with back pain, I prefer fusion. My conclusion, if the back pain predominate and have the dynamic film show instability, I prefer, in the young, I prefer the decompression with back fusion. Is less than 40, I prefer endolift. But if in between, if the dynamic view is stable, maybe decompression alone. But if radiculopathy and the patient more than 60 years old, decompression alone. Thank you for your attention.